to the next speaker, Dr. Ong Hon Shing. Dr. Ong is a corneal consultant at the Singapore National Eye Centre, and he'll be talking about optical coherence tomography in corneal surgery.
Okay, you can see my slides.
Yeah, we can.
Yes.
Okay, thanks, Chiwai. I'd like to thank SSO and the AIOS committee for the invitation to give this talk. I'll be going through some of the current applications, the use of OCT, and some of the future advancements in this technology in corneal surgery. So OCT was initially introduced using the time domain technology, where the reference mirror moves linearly over the eye and multiple readings are generated to create individual A scans. An example of this is the Zeiss Stratus OCT, which can give scans rates of about 400 A scans per second with an axial resolution of 8 to 10 microns in the eye. By the end of the 1990s, technology moved to spectral domain OCT, which allowed a dramatic reduction in scan time by capturing the complete A scan data relative to a single focus point. And this is done without the mechanical scanning of the reference mirror, and it's using high-speed spectrometers instead. And this can achieve axial scanning speeds of over 25,000 A scans per second with an axial resolution of approximately 5 microns in the eye. And this is 65 times faster and approximately twice the resolution compared to the earlier time domain OCTs. So examples of these for anterior segments are the OptoView or RTView and the Cirrus HD OCT platforms. So I'll now show you some of the clinical applications of OCT in my practice when I manage corneal diseases. So this is a young patient with bad atopic keratoconjunctivitis. Due to uncontrolled inflammation, he suffered a corneal perforation, which required corneal gluing, as you can see. And after 6 months, the glue had fallen off, and the surface has healed, although there was still a significant thinning and scarring. So a deep anterior lamellar keratoplasty, or DALK, was planned for this patient. And for all my transplant patients, I perform an RT view to accurately evaluate the corneal thickness. And preoperatively, as you can see from this RT view image, that the thickness is about 200 microns. And this allows me to plan for surgery. And this is another patient with very poor ocular surface and neurotrophic keratopathy, which may be related to a chemotherapy. And her corneal thinning has progressed to a descemetocele, as you can see on this RT view image, with thickness of only 44 microns. So this is a surgical video of the first patient who had the corneal perforation with glue. So firstly, I mark the center of the cornea and place suture markers. Then I estimate the thickness of the cornea using an intraoperative ultrasound pachymetry. So intraoperative ASOCT also allows me to assess which areas of the patient's corneas are thin. And also we use the Henner trephine to make the initial trephination of the cornea. And then I proceed to take the various layers of the cornea off. So using intraoperative OCT, I know that this area of the cornea is, the central area is relatively thin, and this is the area where there was the original perforation which needed gluing. So I avoided these areas and left this area untouched until the end. So there's a marginal dissector which allows blunt dissection of the deep corneal stroma. But unfortunately, at one point, I gone slightly too deep and resulting a micro perforation, as you can see, with a leak of aqueous with the corneal scissors. And I immediately injected air in the AC and continued the dissection. So this is shows that I've reached the desired depth of 60 microns and ready to place my graft on. So to get good vision in DALK, I try to aim for residual thickness of sub 100 microns, and this is a good depth. I've left the central area thin, as I mentioned earlier, to take off at the end, which I expect to have a hole due to previous perforation. So similarly, I injected air into the AC, and I was able to use residual stroma to tamponade the microperforation. And given that there's 2 microperforations in this case, the risk of postoperative double AC is high. So, this intraoperative OCT allows me to assess whether there's any posterior lamellar detachment to avoid a postoperative double AC. This is post-operatively showing a clear corneal dot graft, and RTView ASOCT shows full attachment of the Descemet's membrane despite the 2 microperforations. This is another patient with an almost opaque cornea, as you can see, due to severe bullous keratopathy. She had a previous penetrating keratoplasty followed by a DSEC under this PK, and she underwent multiple glaucoma surgeries. And you can see a severely swollen cornea on this RTView image with measurements of over 1,000 microns. And you can see actually her old Descemet's graft underneath, which is also quite swollen and starting to detach from her penetrating keratoplasty. So I plan to change her DSEC graft. So this is her surgical video. So the intraoperative ASOCT is very helpful in these circumstances where the view of the anterior chamber is limited, and you can see how opaque the cornea is. Sometimes by removing the epithelium, you can see you can improve the view, but you can see this view is still quite limited. So for I normally go through a 4.5mm scleral incision, but for her, I did a limbo tunnel incision because of previous glaucoma surgeries where her conjunctiva and sclera is quite scarred. So I'm using a reverse Kinski hook and also a forceps to remove her old DSEC graft under her original PK, and this is a 23 gauge forceps to explant the graft. So this is her old DSEC graft that you saw on the RTView image preoperatively. So from the OCT images, I'm able to assess the posterior graft host junction, which is helpful in sizing of the DSEC graft. And also I can see that there's not much PAS, which need to be released before graft insertion, which is difficult to visualize because of extremely swollen cornea. So this is graft insertion using the endoglide. And in these cases of limited view, normally I stain my DSEC grafts. I normally don't stain my DSEC graft, but I stain in these cases of opaque corneas with trypan glue to give a better visualization. So this is after air tamponade, and you can see intraoperative OCT showing the attachment, the DSEC graft is fully attached at the end of the surgery. This is following a full air tamponade. So post-op, her DSEC graft is fully attached, and you can see that her cornea is relatively clear even at day 1 compared to her opaque corneas preoperatively. And her edema has improved markedly with the newly transplanted functioning endothelial cells. One of the difficulties, so moving on to DMEC, one of the difficulties of DMEC is graft orientation following insertion to the eye. And this is a different OCT platform. It's a Leica and Focus intraoperative OCT, which allows continuous monitoring, unlike the Zeiss OCT. So intraoperatively, by assessing the direction of the DMEC scroll on the OCT, the orientation of the graft can be assessed as the DMEC has a tendency to scroll endothelium outwards. So you can see at the end of surgery, on the ASOCT, the DMEC graft is fully attached before we close up. So how about in the field of translational research? So this is something that we've been working on in CERI, our Eye Research Institute, and this is a surgical video of cultivated human corneal endothelial cell injection therapy on rabbits. So a silicon tip cannula was used to scrape the Descemet's membrane to remove all rabbit corneal endothelial cells. Trypan blue was used to assess the areas of Descemet's membrane that's denuded of corneal endothelial, which stains blue. And then cultivated cells injected. You can see that the injection of the cells through the OCT. So we showed significant clearing of the cornea in rabbits that received the cultivated cells compared to controls. And this is the use of the RTView OCT showing that the corneal thickness, which corresponds to the distribution of the cells that you can see on this electron microscopy, is thinner compared to the areas where there was no injected cells. So, and we think that even on the OCT, we can see some of the cells that are visible on the posterior cornea. So having seen some of the practical applications of anterior segment OCT, so what next? So current ASOCT of the human cornea can give best resolution of, as I mentioned earlier, 5 microns. And even with the with RTView, where we still cannot identify the cornea layers directly. So one of the more recent advances in OCT technology is the introduction of ultra high resolution, or UHR OCT. And they've been used to visualize things like blood cells, including leukocytes and platelets. And this is the use of a micro UHROCT with a resolution of under 1 micron to render histology-like images of the corneal endothelium. And it's comparable, as you can see, to IVCM, which is in vivo confocal microscopy, and SEM, which is scanning electron microscopy. So UHROCT has demonstrated the capability of distinguishing corneal nerves and also things like limboepithelial stem cells. But UHROCT are currently still limited to academic institutions, and more user-friendly and commercially available platforms should be the next step in the development of OCT. So that's my 10 minutes. So I'd like to thank Prof. Job Matters for some of the contents in this talk, and thank you very much for listening.